Moving towards our second topic, that is focused on use of non-insulin therapies in diabetes management in hospital. To enrich us about this, we have a speaker with us, Dr. Koushik Biswas, a famous endocrinologist having more than 15 years of experience. Due to some medical emergency, he will join us virtually. And to chair the session, we have none other than Dr. Sanjay Shah, the founder president of HDS, and Dr. M.L. Bansali, a famous medical consultant, and Dr. R.L. Joshi, the renowned interventional cardiologist. Then I would like to request our chairperson, Dr. Joshi, to please start the second session and welcome our speaker. He will join us virtually, Dr. Koushik Biswas.
Hello, good morning. Today Dr. Koushik Biswas will be discussing about the use of non-insulin therapies in diabetes management. So I will request Dr. Koushik Biswas.
Thank you, sir. Am I audible?
Dr. Biswas, give me a minute. Let me just check with the physical name once.
Yes, Debolina. Sir, it's audible. Dr. Koushik.
Okay, fine.
Yes.
Okay.
Yes.
Sir, so you can share your screen now? Yeah, can you see the screen now on the...
Yes, it's there. Okay.
Okay. Not this one, sir has shared another... Yes, I think we are okay now.
So we are okay now, right? So, good morning everyone, and I am proud and privileged that I am associated with Howrah Town Diabetes Study Society, and I am very grateful to them to become considered as far as considering my emergencies. Today my topic of discussion is use of non-insulin therapies in diabetes management in hospital. Now, what is hyperglycemia in hospital setting? Any blood glucose more than 140 mg per deciliter is defined as in-hospital hyperglycemia, which is a common scenario across the world, affecting patients with prior diagnosis of diabetes or those with stress hyperglycemia or any medication-induced hyperglycemia such as steroid. The prevalence may vary according to the country and according to the settings. However, the overall prevalence can be 30 to 40% in hospitalized patients. In 20% of people without a diagnosis of diabetes presenting to an emergency department may have newly recognized hyperglycemia, and that newly detected hyperglycemia or in-hospital hyperglycemia per se is of utmost clinical importance. Why? Because inpatient hyperglycemia is an independent risk factor for increased morbidity, increased all-cause mortality, increased hospital stay, and of course, increased health care expenditures. Now, if we go back 20 years, many clinicians did not pay attention to hyperglycemia at that time in hospitalized patients. Unfortunately, till today, many of our surgeon colleagues only care or mostly care about clearance for surgery, but perioperative glycemic control are often not at par. The management relied on that time, 2 decades ago, mainly relied on continuing home medications, including metformin and sulfonylureas, with the addition of sliding scale insulin therapy. The heavy reliance on the so-called sliding scale insulin therapy, which is a very reactive approach, and it leads to roller coaster effect on blood glucose monitoring, leading to extremes of glycemic swings, which itself is an indicator of bad prognosis in the hospital setting. Now, what are glycemic targets in non-ICU settings in hospital? The pre-meal blood glucose should be less than 140 mg per deciliter, and random blood sugar should be less than 180 mg per deciliter. However, individual addition can be done. A lower target can be achieved without risking the patient undue hypoglycemia, and a higher target may be set in case of vulnerable populations when the likelihood of development of hypoglycemia is much higher. So modification of regimens should be done when the blood glucose is less than 70 mg per deciliter. Now in ICU setting, there was great studies like Vandenberg studies followed by nice studies and lots of RCDs stating that ultimately in ICU setting the standard of care would comprise a blood glucose level between 140 to 180 mg per deciliter. But in non-ICU setting, the lack of evidence regards RCDs to assess benefit of improved glycemic outcomes in general medicine and surgical patients. One of them is RABBIT-2 trial, which compared basal bolus insulin regimens versus this so-called sliding scale regimen, which we often use in our day-to-day clinical practice. And multiple trials, including RABBIT-2 trial, had shown that basal bolus insulin regimen is superior than sliding scale regimen, and largely sliding scale regimen could be abandoned in hospital setting. Now, few days ago, just the Endocrine Society Clinical Practice Guideline had been published in 2022 regarding management of hyperglycemia in hospitalized adult patients in non-critical care setting, state that in most adult patients with hyperglycemia, with or without known type 2 diabetes, we suggest that scheduled insulin therapy be used instead of non-insulin therapies for glycemic management. Given that, having said that, or given that pretext, I understand or try to place the oral hypoglycemic agent in the non-critical care settings, because we know not all patients which are hospitalized require basal bolus regimens, and we have new antidiabetic agents which have different mechanism of actions and with lower risk of hypoglycemia. Not only that, there are potential other regions to avoid insulin regimens in some cases, because basal bolus regimen is complex, it's labor intensive, and there is the risk of hypoglycemia is high. Now, what are the problems with agents other than insulin in a hospital setting? Regarding sulfonylurea, hypoglycemia, metformin, increased lactic acidosis, especially in a hospital setting, I will discuss it later. Thiazolidine, it has a very slow onset of action, it is contraindicated in heart failure, in some other conditions. DPP-4 inhibitors are less useful in patients with decreased food intake. SGLT2 inhibitors can be associated with dyslipidemia and ketoacidosis, and GLP-1 receptor analogs are associated with nausea and vomiting. Now, what are the criteria or in which conditions we can continue the non-insulin agents? When there is low risk, stable patient with A1C less than 8%, pre-hospital A1C less than 8%, eating greater than the patient who is admitted eating greater than 50% of regular diet, expected discharge within 1 to 2 days, no plans for contrast studies, no acute renal failure or glucocorticoid therapy or infections. Now, regarding use of DPP-4 inhibitors, we know DPP-4 inhibitors, we are using that molecules since last 1 or 2.5 decades. It's very well tolerated molecules with with modest efficacy in reduction of HbA1c, and it almost does not produce hypoglycemia. Now, there are several studies. For an example, a study in sitagliptin along with basal in one shot of glargine was compared with basal bolus insulin therapy comprising one shot of glargine and 3 shots of short-acting insulin. So, and in that study, it was shown that in patients with moderate hyperglycemia who are admitted, if they are treated with sitagliptin and basal insulin alone, the glycemic lowering efficacy will be similar to the basal bolus therapy with less incidence of hypoglycemia. Not only sitagliptin, in case of saxagliptin in surgical ICU patient, this kind of approach was proven, and in case of linagliptin in medical world, the efficacy of linagliptin in hospitalized patients was also established. So these studies suggested patients with moderate to mild to moderate inpatient hyperglycemia, and especially in patients who are vulnerable to develop hypoglycemia, such as elderly and who are having poor intake, and renally impaired patients sometimes be safely managed with DPP-4 inhibitors supplemented by correctional dose or basal insulin. Now, these are the main settings where DPP-4 inhibitors can be utilized, like moderately well-managed diabetes, such as HbA1c less than 7.5 to 8%, admission blood glucose less than 180 to 200 mg per deciliter, and when the pre-existing daily insulin dose is less than 0.6 unit per kg per day. Now, regarding GLP-1 receptor analogs, several studies, small studies have indicated that during the cardiac surgery or during a cardiac event, infusion of native GLP-1 molecule or GLP-1 receptor analog may protect the myocardium. However, these are all pilot studies. One of the clinical pilot studies, I have been given that example here, comprising 150 patients, where 3 groups are there. One group received liraglutide 0.6 milligram at the evening before surgery. The other 2 group receives insulin infusion and insulin bolus respectively. The primary outcome of that study was to see the median glucose level 1 hour post-surgery. And you can see from the table that glucose 1 hour post level was significantly lower in liraglutide group. The mean was 6.6 in comparison to other 2 groups. So, small study, but it was established that liraglutide can be beneficial in terms of reduction of blood glucose, even comparison to insulin infusion. However, the incidence of nausea and vomiting was much higher in case of liraglutide. Similar thing happened in another pilot study involving exenatide twice daily, exenatide BD, on top of glargine, glargine 100 once daily, in comparison to basal bolus regime. Again, the glycemic lowering efficacy was better in exenatide BID group along with basal insulin. However, the rates of nausea and vomiting were significantly higher. So, I am putting this review article that animal and human studies have reported improvements in myocardial performance when given activity after vascular insult or in the surgery, but these have yet to be translated into the randomized clinical trials. Till to date, we are not accustomed to use GLP-1 receptor analogs when patients are hospitalized. Regarding SGLT inhibitors, we have just gone through a very pathetic pandemic, COVID-19, and this is one of the first kind of study where an SGLT2 inhibitors has been used in an acute setting. Here, the DARE-19 trial, and giving the example of dapagliflozin, where around 1200 patients were randomized to either 10 milligram of dapagliflozin and placebo who were infected with COVID-19, and the exclusion criteria was those who are on mechanical ventilations, having significant renal dysfunction, decay, type 1 diabetes or hypertension. The primary objective of their 19 trial was to see the composite of new or worsened organ dysfunction during hospitalization or death from any cause during the treatment period. You can see that the primary composite outcome, these were not significantly different. Dapagliflozin was non-inferior or not superior. But my point here, if you see this adverse effect profile in that study, if you see the placebo versus dapagliflozin in that trial, if you look at the AKI percentage and the big death, there was no significant difference in any serious adverse event between dapagliflozin and placebo. So even in that acute setting, though the objectives are different, but at least it is reassuring that dapagliflozin was not associated with any serious events in the acute setting. In one of earliest trial, in acute heart failure involving SGLT2 inhibitor is soloist WHO trial involving sotagliflozin, in which the acute decompensated heart failure patients were included, and the patients were randomized to either sotagliflozin or placebo, and the primary composite outcome was the CV death, HHF and urgent heart failure visit. And you can see how the Koushik curves separated very early, and it was very significant in favor of sotagliflozin. Unfortunately, because of the lack of funding, the drug development program stopped prematurely. But this is an indication. This is one of the earliest indications during acute heart failure how an SGLT2 inhibitor can provide a significant benefit. Lately, we have two other publications, small RCTs involving empagliflozin. I have quoted one of them. There is the Impulse trial, which is an RCT involving 530 patients with primary diagnosis of acute de novo or decompensated congestive heart failure, irrespective of ejection fractions. Whatever their ejection fractions, they are randomized to either 10 milligram of empagliflozin or placebo, and they are given after initial stabilization for a mean duration of 3 days, and the primary composite outcome. A primary outcome, the trial was the composite of death from any cause, number of heart failure events, and time to first heart failure event, or a 5-point escalation of Kansas City cardiomyopathy questionnaires from the baseline at 90 days of the initial hospitalization randomization. As you can see, the win ratio is clearly favoring clinical benefits of empagliflozin in acute heart failure setting in comparison to placebo. Remember, this is a multi-center, multinational, randomized control trial. It's a very well-designed trial. So again, empagliflozin SGLT2 inhibitors is found to be safe in the acute setting of acute heart failure. SGLT2 inhibitors by and large should be avoided in cases of severe illness, in patients with ketonemia or ketonuria, and during prolonged fasting and surgical procedures. In fact, FDA recently warned that SGLT2 inhibitors could be stopped 3 days prior to scheduled surgery and 4 days in case of R2 Regarding metformin, still to date, a large number of patients, around 50% of patients who are admitted in hospitals in the developing countries continue to receive metformin. I love that molecule, but during hospitalization, I do believe, as stated by most of the stakeholders, the metformin is better be avoided in hospital settings because there is often changing dynamics in the hospital. There is more likelihood of development of lactic acidosis, hypertension, renal failure, sepsis, which can aggravate or which can make it more vulnerable to metformin-related lactic acidosis. So altogether, I believe metformin better be discontinued or not to be used in hospital settings, even in non-critical care setting. Regarding sulfonylureas, I have already told you, even during hospitalization, the rates of hypoglycemia with sulfonylureas are much higher than in patients who are ambulatory type 2 diabetes mellitus. It is between 20 to 30%. And the vulnerable populations are elderly patients and those are having renal failures. And notably, many of them experience recurrent hypoglycemia in hospitalized settings. Most importantly, the hypoglycemia is mainly nocturnal. Though ECOG guidelines allow the use of sulfonylureas to manage glucose extraction in patients taking once daily oral steroid in the morning, the other guidelines, like US guidelines, states that sulfonylureas should not be used in hospital setting in any circumstances, whether the patient is taking steroids or not. It should not be used. Regarding thiazolidine, I have discussed it. Thiazolidine takes a long time to act, so it's not a good thing, good molecule to control blood glucose activity, and it is contraindicated in many settings, so it is obviously out of choice. And this, in nutshell, this is the what I have already said. The future is patient diabetes management. This is my final slide. In that slide, I'll discuss how the personalized treatment in non-ICU hospitalized patient with type 2 diabetes mellitus can be done. If patient is newly diagnosed with no prior treatment, patient is insulin naive, the admission glucose is less than 200 milligram per deciliter, A1C is less than 7.5%, patient is having food poorly, there is high risk of hypoglycemia. It is better to provide correctional bolus dose sometimes, or uses of OADs like DP4 inhibitors. And when the prior patient has a history of prior treatment of more than 2 oral anti-diabetic agents, and patient was already on insulin, but daily requirement of insulin is less than 0.6 unit per kg per day. The admission time glucose is between 200 to 300 and A1C between 7.6 to 9%. Again, poor oral intake. Then basal supported oral therapy like the sitagliptin or any DP4 inhibitor plus one shots of long-acting or ultra-long-acting basal insulin can be considered. On the other hand, when the patient was already on complex regimen at home, when the daily requirement of insulin is more than 0.6 unit per kg per day, when the admission blood glucose is more than 300 milligram per deciliter, A1C is more than 9%, patient is taking food on a regular basis, or patient is having insulin resistance because of steroid, it is always better to start with basal bolus regimen straight away, which we often prefer in hospital setting, supplemented by correctional dose of insulin. And that is how we can categorize our patient and tailor the management of diabetes in non-ICU setting in hospitalized patient using both insulin as well as oral anti-diabetic agents. Thank you for your time listening.
Hello, Dr. Koushik Biswas. You very nicely explained the use about DPP4 and SGLT2 inhibitors in a very elaborate way. That is, even they can be used in the acute cases also. But in as you have already explained, the insulin is the mainstay in emergency cases. emergency cases basal bolus. But when it is the HbA1c is under control, then these all oral medications, they can be very well supplement the insulin or basal insulin or basal bolus. Thank you. Thank you very much. Is there any question you can ask? Yes, Dr. Somani.
This problem when a diabetic patient presents with optic neuritis or a demyelinating event in the form of transverse myelitis, and we have to give methylprednisolone in high doses. In those situations, should we stick to the sliding scale or basal bolus plus as and when required insulin? Sliding scale, or when we are giving steroid in a transverse myelitis case, so to say.
Well, thank you, sir, for the question. First of all, this since last 1 decade, the so-called sliding scale, the word sliding scale has become obsolete. We're not using that term anymore, and we are not using that reactive approach anymore. We have, in those cases where the blood glucose levels are likely to be fluctuating, a variable blood sugar because of the steroids and fluctuating levels. In that cases, there should be basal, either uses of basal. There are clear-cut guidelines. If we can use them, we can use the basal insulin. If it is not controlled with basal insulin, then basal plus and basal bolus therapy can be utilized. And if the patient is not taking meal properly, if there is poor intake properly, in that case, the correctional dose, we cannot fix the bolus doses, but correctional doses can be given according to the pre-meal blood glucose. So, if basal support, either using the first and second generation long-acting basal insulin to be given, and it will be supplemented by the correctional doses before each meal, and that is how it should be mitigated. But theoretically, both theoretically as well as practically, the sliding scale, though widely practiced even in my hospital, but we should move away from that because several studies have shown that this sliding scale leads to roller coaster effects, very extremes of glycemic swings, and it has to be gone. Thank you.
Well, myself, Dr. Koushik from South Kolkata, I'd like to ask you how to titrate basal insulin in end-stage renal disease in diabetic patients, because there is no literature or whatever information to guide us how to adjust the dose. Although we know that basal insulin like degludec are quite safe in CKD patients.
Well, thank you, sir, for the questions. Now, we know that first of all, basal insulin can be used in chronic kidney disease patients. There are studies to show that both first and especially second generation basal insulins are safer to be used, can be used in patients with renal impairment. Now the dose adjustment depends on clinical discretion. In case of chronic kidney disease patient, there is often risk of hypoglycemia because of many reasons, because the altered pharmacokinetics of the insulin, because there is decreased neoglucogenesis, patient may vomit, there is anorexia, so there is unpredictability of glycemic control, so risk of hypoglycemia is much higher. So target setting, the setting a target should be a higher one. For example, if we depending on the scenario, in general patient we target a fasting blood glucose between 80 to 120 or 80 to 130 milligram per deciliter, fasting plasma glucose or fasting or capillary blood glucose. Now, in case of CKD patient, depending on the scenario, that fasting plasma glucose or A1C level target should be set high. Like A1C may be set around 8%, especially those who are on hemodialysis, it can even be set around 8.5%. So that hypoglycemia can be avoided. Regarding titration, the process of titration remains same. We can ask our patient to monitor. I'm just talking about the basal insulin as you have asked. The process is same. I have to fix a target for that particular patient, that I am going to keep a blood sugar between between 100 to 140 milligram per deciliter fasting for that patient, and the titration regimen is same. The patient can titrate in different manner, like in a daily basis, or most preferably twice in a week or once in a week, depending on the self monitoring of blood plasma glucose. And that is similar. We can increase increase 2 units of basal insulin if the fasting blood glucose for that particular example is above. If it is above 140, we will increase the dose 2 units. If the fasting blood glucose is below 100 in that particular renally compromised patient, then we will decrease the blood glucose by 3 to 4 units. This adjustment is similar. The adjustment is same as we do in our general patient. But here the important point is the setting the goal.
Dr. Biswas, thanks for the wonderful talk. I would like to just try to understand a couple of points here. First of all, most of our renal patients, especially those CKD patients or end-stage renal disease patients, they frequently skip the meal and they eat very little. So probably it will be prudent, instead of choosing the insulin first, to do a proper CVG checking at least 3 to 4 times a day. And most of the patients don't require a basal, probably a short-acting insulin before the lunch and one renally appropriate dose of DPP-4 inhibitor covers most of the patients. So very rarely they have requirement of a basal insulin to cover the whole day. And most importantly, these patients, those who are in the end-stage renal disease, unfortunately often they skip dinner. So early morning hyperglycemia is not a clinical challenge. Rather, those patients who are requiring diuretic supports, having profound dysglycemia, primary dysglycemia is probably more profound, and probably 4 or 5 units of short-acting human insulin or appropriate analog insulins solves the whole thing. Definitely basal insulin is definitely one of the safest solution, and of which second generations are definitely superior in terms of their hypoglycemia. But in terms of individualization of the care, probably short-acting insulin coupled with the appropriate DPP-4 inhibitor in renally adjusted dose cares the whole thing. And advantage of that thing is, if a patient skips the dinner or takes the half amount of dinner, we can tell the patient that if the patient is not eating properly, instead of giving 8 units, you either skip or you give half of the dose. So probably that's a safer, less expensive, more customizable and easy to follow up protocol rather than checking weekly thing, because there will be 2 different days, dialysis days and non-dialysis days. So the day we are trying to check the thing, if it is a non-dialysis day, I think putting a patient on basal insulin on a dialysis day when the person will be skipping things, or those patients who are especially on CAPD, on peritoneal dialysis using high dose of glucose, I think this will be catastrophic. Only those CAPD patients will probably require the basal on top of that. Otherwise, basal insulin, do you really require that frequently? This is probably I try to clinically answer Dr. Ghosh's concern. Otherwise, though, you have very nicely explained the whole thing. Thanks once again. I hope you are recovering very well now. I remember you've been unwell, so hopefully you are getting well soon.
Thank you.
If there is no further question, we close this session. Thank you. Thank you, Dr. Koushik Biswas, for such a nice lecture.
Thank you, sir.
Thank you very much. Thank you.
Thank you so much, speaker. Thank you so much, chairperson, for such an interactive session.